Good afternoon, everyone, and welcome to Open Classroom. I'm Janet Gillow, Director of Professional Development for the Brown School. I'm joined by my co-host, Joshua Walewa, who's our Associate Director for Admissions and Recruitment. Welcome to today's program, which is Public Mental Health, why it is what it is and why it is now more important than ever, delivered by Associate Professor Alexis Duncan. Alexis's research focuses on psychiatric comorbidity of obesity, eating disorders, and substance use disorders, particularly among women. She's a psychiatric epidemiologist with training in behavioral genetics. She takes a transdisciplinary approach in her scholarship to foster a comprehensive understanding of disease and effective treatments and interventions. Really looking forward to this conversation. As those of you who have been with us in the pre-chat, Alexis is really on the cutting edge of considering the impacts of the current pandemic. With that, I pass things over to Alexis.
Thank you. Okay, I am now going to share my screen and so that you can see my slides, which I'm going to start now. Oh, someone raised their hand.
So that is your Internet Explorer, and now we are good.
Okay. So I'm gonna start with a disclosure here that this is my first ever Zoom lecture. So we'll see how it goes. And you're welcome to post questions in the chat, and Janet and Joshua will be moderating that, and we can stop as we go to answer questions. Okay, so this is very appropriate for me to be giving this talk right now. I didn't realize it when I signed up, but this is Mental Health Awareness Month. And that's what these, I don't know what color you call that, kind of Kelly green? I don't know that's even Kelly green, but anyway, those ribbons mean they're for mental health awareness. The World Health Organization describes mental health as a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. As depicted in this figure here, on positive mental health from the Public Health Agency of Canada, that's the Canadian CDC. The mental health is affected by factors at a variety of different levels. You might recognize this as a version of the ecological model. So we have factors at the individual level, like our health behaviors and psychological makeup, as well as familial factors, like health and mental health of our family members. Then community level factors, such as relationships with friends and neighbors, and the physical and social environments in the places where we spend a lot of our time also contribute to mental health. For example, the built environment affects our mental health, which that's something a lot of my colleagues at the Brown School study. Furthermore, mental health is affected by societal level factors. So things like racism and other forms of inequality and discrimination and stigma. Now, many people argue that mental health and mental illness aren't necessarily opposites of each other, but they are highly correlated. It is possible to have poor mental health, but not have a mental illness or mental disorder, and vice versa. And it indicates that at the bottom of this figure in little tiny print. So I've made it bigger for you. And it says a positive mental health is important for all Canadians and all people, including those with mental illness. So now let's talk for a minute about mental illness, also known as mental disorders, and lots of other synonyms, as I'll show you in a minute. Again, with the World Health Organization definition, is that they're disorders characterized by a combination of abnormal thoughts, emotions, behavior, and relationships with others. And in the US and in a lot of the rest of the world, We define mental disorders by categories set forth in the American Psychiatric Association's Diagnostic and Statistical Manual, or DSM. Also, we may use the ICD, International Classification of Diseases, to define mental disorders. Either way, it's important to note that there are no biological tests for mental illness. Mental illnesses are syndromes, so a collection of signs and symptoms that tend to hang together. And terms for these disorders are often used interchangeably. I tend to use them interchangeably myself. So take note of these, that I'm using them all synonymously, but do be aware that different disciplines tend to include more or fewer types of diagnoses under their definitions. So for today, just to make it clear, I'm going to tell you that in public mental health, when we use the term mental disorders, we mean that to encompass diagnoses like schizophrenia and depression, as well as substance use disorders. And that often people include certain developmental disorders like autism spectrum disorder and neurological disorders such as dementia under the umbrella of mental disorders. Now, we don't know the precise mechanisms that cause mental disorders yet, but we do know that mental disorders are caused by a combination of complex genetic factors and environmental factors. Environmental factors that are like those in that figure I showed you earlier. So things like trauma, socioeconomic status, and social support. The evidence points to some mental disorders like schizophrenia and autism spectrum disorder as being more strongly influenced by genetic factors, and other mental disorders such as depression are thought to be more strongly influenced by the environment. But either way, it's not nature or nurture, it's nature and nurture. Mental illness is quite common in the US. It's thought that 1 in 5 or 20% of adults have had a mental illness in the past year. In kids and adolescents, it's 1 in 6. And almost half of people meet criteria for at least one mental illness in their lifetimes. Mental illness, as you can guess from the 1 in 6 versus the 1 in 5, starts early. About half of people who ever have a mental illness have their first diagnosis before age 15, and 3/4 experience onset before age 24. So 20% in the past year, 50% in lifetime is a lot of people. That sounds like a big public health problem. But for a variety of reasons, the specific subfield of public mental health is relatively recent development. It's so recent, in fact, that there isn't a textbook definition of public mental health. In fact, there are only a couple of textbooks at all. There are 2 that I know of. And neither of them have a universally, they say there's no universally agreed on definition of public mental health. So I have had to come up with my own, and I'll share it with you, but note that it's a work in progress. So I would say it's a relatively new subspecialty of public mental health that uses public health methods to address mental health at the population level. So the important thing to note here is public health. So it's population. We're looking at things at the population level, and that's opposed to, say, psychology or medicine, which tends to focus on the individual level. Now, mental health hasn't traditionally been thought of as within the boundaries of public health, but in the past 2 decades, public mental health has become increasingly prominent, thanks in part to increasing recognition that mental and physical health are not separate from one another. So we're rejecting the mind-body duality. In addition, we have recognized that mental disorders represent a substantial public health burden, and that public health methods are applicable to mental health. Contrary to popular belief, there's a lot more that can be done to address mental health than one-on-one sessions with licensed mental health care providers. But if you are a licensed mental health care provider, don't worry, there's still plenty to do. There's room for all of us. So these last 2 points, I couldn't decide what to put first, because the reason we know that mental disorders represent a substantial mental health or substantial public health burden is because of one of the public health methods, namely epidemiology. So epidemiology is one of the core disciplines of public health, and it's often considered the core discipline. Of course, I'm biased since I'm an epidemiologist. I love epidemiology, really. So unlike public mental health, there are lots of epidemiology textbooks, and all of them contain definitions of epidemiology. Epidemiology as a field has been around for maybe 170 years, so they've had lots of time to come to a consensus. So here's one of them. It's the study of the distribution and determinants of health-related states or events in specified, there we go, populations. The application of this study to control health problems. So a few important things about this. First of all, I've already talked about epidemiology when I talked about the prevalence of mental disorders, which is the distribution of mental disorders, and their causes, or the determinants of mental disorders. And another, perhaps the most important thing here, is that we use epidemiology to inform policy and prevention. So this is relevant to public mental health because traditionally public health is focused on conditions with the highest mortality. So we've cared most about the diseases that are most likely to kill people, which makes sense. And even if something affected a lot of people, if it didn't actually kill people, it wasn't considered a priority. In the past couple of decades, however, we've also started to consider conditions that cause more morbidity. In other words, we've shifted our focus to conditions that cause more disability, those that prevent people from fully participating in life. And we've come up with some ways to quantify this, such as disability-adjusted life years, or DALYs. And these can be thought of as lost years of healthy life attributable to a health condition. And here we see the top 10 causes of disability in the US in 2010. And you can see that the biggest, or the leading cause of disability here is neuropsychiatric disorders. And you may recall that's one of those synonyms for mental disorders or mental illness. It includes here neurological disorders such as Alzheimer's disease. And if we look more closely and break up these categories into individual diagnoses, we see that major depressive disorder alone ranks as the 5th leading cause of disability in the US. And here I've highlighted some other mental disorders. And note also that major depressive disorder, it's 5th overall in the US. However, if we look at specific age groups, for example, it is often the leading cause of disability through up until older adulthood. And mental disorders are associated with mortality too. Maybe not directly, although we can argue about that a little. But they are associated with, I'd say, 9 of the top 10 leading causes of death in the US. I can't quite make a story for how it might be related to influenza and pneumonia, although, yeah, I can make a story. So if you have a poor mental health, for example, or say you have a substance use disorder, you might be more likely to catch an infectious disease. And that's something that we are seeing with COVID-19, in fact. And So that was a little tangent, but back to mortality and mental illness. It's not surprising, since mental illness is associated with the leading causes of death, that people with mental illness have life expectancies 1 to 2 decades shorter than people without mental illness. So why does mental illness cause so much disability? First, as I've shown you previously, it's very common. So that would cause a lot of disability if it's affecting the way people function in their lives. Furthermore, the majority of mental illness goes untreated. On average, 11 years elapse between the onset of symptoms and the start of treatment for those who do get treatment, but most don't. The majority, I already said that the majority don't, and there are disparities in who gets treatment and in who doesn't. For example, as you can see on this infographic here, white adults are more likely to receive treatment than adults of color. And all of this because of associations between mental disorders and other health problems contributes to broader health disparities. So another reason why mental health and mental disorders have been largely absent from public health in the past, or until recently, is because they're highly stigmatized. Traditionally, mental health and illness is something that we just don't talk about in polite company, and something that we ignore or whisper about behind closed doors. And if we don't talk about it, then it's hard to do something about it. So more recently, mental health has become more of a topic of conversation. And do whatever you think about advertising, say antidepressants on TV, they did bring discussion of depression into the public forum. And public figures like these here and many more have talked openly of their struggles with mental illness. And this has started to help normalize and destigmatize mental illness. We still have a long way to go. Even if stigma weren't an issue, there's still lots of barriers to seeking and receiving treatment for mental illness. So first, a person has to recognize that there's an issue that's interfering with their ability to function in their life roles, and be willing to seek help. Stigma can be a barrier to that, but there are other barriers too. Then, even if one wants help, there has to be help available. In the US and in much of the world, there are not mental health care providers available. And in particular here, for example, there is a shortage of healthcare providers, mental health care providers for adolescents and children, and a dire shortage, I would say. So if you're going to medical school, consider child and adolescent psychiatry or treating children as a therapist. Let's see. So even if care is available, we may not be able to afford it because we may not have health insurance, or even with health insurance, it's too expensive. Or, and that it may be too expensive even with health insurance because a lot of providers don't take insurance. And there's also quality of care, which is another issue where not all providers use evidence-based treatment. So addressing all of these things, stigma and barriers to treatment, these are all firmly within the wheelhouse of public health. And let's not forget prevention. In public health, we're all about prevention and early intervention. We aren't content to wait until somebody with diabetes needs to have their foot amputated to give them treatment. Instead, we promote healthy lifestyles and we try and prevent diabetes from developing in the first place. And we also, if it does happen to develop, we try and catch it early so that we can prevent people from having to have their feet amputated. The same needs to be true for mental illness. And Now, we do have a long way to go before we're at the place where, say, diabetes prevention is. But I am happy to say that over the course of my career in public health, I've definitely seen an increase in public mental health activities. So some things that have been done or are being done, anti-stigma campaigns, like here I have this little thing I found just searching stigma and mental illness. So this was a campaign from Michigan, in green, I guess, probably for Mental Health Awareness Month or Week, about stay no to stigma. You may have seen there's various hashtags with stigma, stop the stigma. Let's see, social and emotional learning programs in schools are mental health promotion and prevention of mental illness. So teaching kids how to interact with one another and manage their emotions appropriately. We've enacted mental health parity laws, although they leave something to be desired. We are at least thinking along those lines that mental health is equivalent to or part of health. And then we have done things, and I've been involved in the early stages of our project, doing educating non-mental health care providers to identify mental illness and provide brief interventions or referral to specialty care. And in the 21st Century CARES Act, for example, there's a provision to do this with regard specifically to eating disorders, which are very unrecognized. That's one of my topics of work. So we develop and implement policies and programs, and then we evaluate them in public health, in public mental health, just like in public health, because it's part of public health. And of course, we would like to do, I don't know if you can see my cursor here, probably not, there we go. It's important to engage stakeholders. And although it doesn't say in this framework because it's about evaluation, but as we, both with evaluation and in terms of development, we also need to engage stakeholders and in particular, people who have the conditions that we are trying to impact. And of course, we are going to and have been conducting surveillance and research. Now, the amount of surveillance and research dollars are not necessarily applicable to the disease or commensurate with the burden of mental disorders. So this is an area for policy to increase funding. But we need to conduct surveillance to aid in the evaluation of our policies and our prevention activities. And we need to conduct research to learn more about the causes of mental illness. The more we know about causes, the better we'll be able to intervene. And I just a little plug here that since most people get treatment, it would be best, in my opinion, to do research on causes in people from the general population. That would include people who do and don't get treatment, rather than just people who are in treatment, as is commonly done. So that's a little bit about public mental health. And so now let's talk about public mental health during our current crisis. And that's the whole reason we're doing it today on Zoom instead of in person, is we've got this crisis caused by the novel coronavirus. And in an effort to contain the spread, we've done a lot of things that have potentially affected our mental health. And many of us warned early that this was likely to cause a significant increase, or some would said a tsunami of mental health issues. And it's on this sign, it says what to do if there might be a tsunami. If there's an earthquake, so there might be a tsunami, and it says go to high ground or inland. And the way I think of it here is that we're on a barrier island and there's no way to get to the mainland. And so before I launch into all the negative effects of the pandemic on mental health, I wanted to take a minute and invite you all to put in the chat if you'd like, and we'll come back to it in a little bit. But if you have noted any positive effects on your mental health and well-being during the pandemic, because people have reported some positive effects, and I'd like to acknowledge those. Largely, the effects have been more negative. So why have we been warning about this tsunami? It's because there's been an increase in risk factors associated with the measures that we're taking to slow the spread of the virus and the virus itself, and a decrease in protective factors. And by and large, we expect that's going to lead to more mental illness and poor mental health and well-being. And remember, these things are highly correlated, but not necessarily exactly the same thing. To unpack it a bit, we've seen an increase in risk factors such as stress. I guess I don't really need to go into that. I'm sure we all are well aware of how it's causing stress. Life is uncertain, which is anxiety-provoking, and particularly for people who already have anxiety, it exacerbates that. There's been an increase in trauma. For example, domestic violence has increased. And there's trauma associated with both getting the disease, even if you survive, and for the loved ones of people who get the disease, who have more severe illness, and those who don't make it, as well as, and we've heard a lot in the news about the trauma that healthcare workers are experiencing in caring for the sick and the dying. I've also heard about an increase in alcohol and drug use, and that even people who have previously been in recovery for substance use disorders are reporting that there's been an uptick in relapses. And even before the pandemic, there was what's been described as an epidemic of loneliness, with over half of people saying that they're very lonely. Recent surveys have found that loneliness has increased. People, the majority of people are saying that they're even more lonely now than they were prior to the pandemic. And then, of course, there's grief and loss associated both with deaths of loved ones, particularly when people haven't been able to be at their bedsides, like in this painting, and when they haven't been able to mourn with their friends and family. And there's grief and loss associated with being separated from friends and family and from missing out on important life events, you know, proms and graduations and weddings, things that people have been planning for and looking forward to for years. And we've also decreased protective factors, and things that promote mental health and well-being are in short supply. People are getting less physical activity. Sleep has been disrupted. Now, we do have, we may or may not have less social support in terms of contact with other people, but that contact is different. Social media and Zoom are poor substitutes for in-person interaction, particularly when touch is a basic human need, and many people, especially those who live alone, have gone months without touching another person. Churches and self-help group meetings are closed, churches are closed, self-help group meetings have been suspended. In some places, beaches and parks are closed. And then we can't forget about declines in physical health related to the virus, because physical and mental health are highly entwined. And thus, it's no surprise that, as reported in this article from the Washington Post earlier this month, that almost half of Americans say the pandemic is harming their mental health. In this article, it reports there's been a 10-fold increase in the use of a federal emergency hospital hotline for people in emotional distress. there's been a lot of talk about the possibility of an increase in deaths by suicide. And there have been articles that have shown that there might be an increase, but the jury's still out on that. And it's important to note that suicide rates have already been increasing, so we're going to have to take that into account. But either way, we know that it is negatively affecting mental health. So who is at risk? Now, mental ill health and health conditions in general, they're not distributed equally. So last week, a UN policy brief on COVID and mental health was released, and they listed these groups of people as having a high risk of increase in mental illness. Healthcare workers, so experiencing a lot of stress and trauma. Older adults who may be more susceptible to loneliness, and people with pre-existing conditions who also might have more anxiety over getting the virus since they're at higher risk of death. Children, adolescents, and emerging adults for several reasons. Kids who are shut up at home, perhaps in abusive households, might have increased risk of trauma. Emerging adults, so those are people that are college age and a little beyond, maybe 18 to 25. And remember when we talked about the timeline when most mental illness onsets, this is a very vulnerable period. And these children and young adults are not able to have the social support that they crave and need. Women, again, for this increase in domestic violence that women are often the victims of, and women also have many added stressors in being at home with the children. People in humanitarian and conflict settings that are already at high risk of developing mental health problems due to trauma and, again, lack of a social network. And then these weren't in the brief, but I wanted to add that other groups at high risk are people with a history of mental illness. So mental illness tends to be episodic, and so people may have increased risk of developing symptoms again, or worsening of symptoms. And finally, people who've survived the COVID-19 infection. There's emerging evidence that there are mental or neuropsychiatric issues, say, in COVID-19 survivors. So in addition to mental health diagnoses, also cognitive issues. And we don't know yet whether these are going to be short or long term. Okay, so here is where I wanted to stop for a minute. And I've just talked about all sorts of negative stuff. Has there been any positive stuff that has come out of the pandemic?
So Alexis, yes, on the chat, many people were able to identify positives. Shall I rattle off some of what we heard?
Sure.
Okay, so the opportunity to spend more time with family, have meaningful conversations, realizing that time can't be taken for granted, to be able to spend some time outside, learning acceptance of uncertainty, learning new ways of doing business, many of which appear to be beneficial to clients, not being stuck in traffic, to have an opportunity to clarify and slow down a hectic life, increased bonding with family and friends, starting a business, eating home-cooked meals, which are healthier, being intentional to exercise, less pressure to always be doing, more time for self-development, less stress rushing. This person saying not her own, but some people with social anxiety may be feeling less anxious, more intentional self-care. So lots of people saying slowing down and the opportunity to be intentional and connect. And
yes, there are good things And a lot of those I feel myself, like I've connected with people who I have not talked to in many years. And I suspect that what's going to happen is that there are going to be, well, good things and bad things for everyone, but that the effect is not going to be the same for everyone. Which, to put on my epi professor hat, would be an example of effect modification. Okay, so after our positive break, well, this is still positive. So what are we doing about it? So we saw this coming, although we didn't necessarily see it coming with enough time to put a lot in place. But we did start talking about it as soon as people felt sure that this, say there was an earthquake and people weren't sure there was a tsunami coming. So as soon as the tsunami was detected, then people started talking about it. That there's likely to be, oh, I had meant for you to be able to see both of those, but that there's likely to be an increase in mental illness, perhaps in suicide mortality, and then have suggestions of things that we might do about it. And so what have we been doing? Well, right away, I can attest at the Brown School, people started thinking about and talking about research. And so we mobilized very quickly and to do research on the mental health effects of the pandemic. And we can use the information to better understand how environmental factors affect mental health, so not specific to the pandemic. And we can use it to calculate the increase in the burden of mental illness associated with a pandemic down the line. We can also potentially use the information we're gathering now to plan for how we might handle future lockdowns if they become necessary. And to minimize the, so what we'd like to do in the future is minimize the impact on mental health. And as an aside here, I'd say that the leading experts in epidemics don't think that this is over. So we do need to be thinking about what we're going to do in the future. Governmental and non-governmental organizations and even companies like Google have made efforts to, or campaigns to encourage behaviors to promote mental health. So when I did a search earlier on COVID and suicide on Google, this is what came up. You all may have seen it. And here's a little infographic from the World Health Organization, and we've seen these things, and I've seen them all over in the news, etc., about how to minimize the negative impact, cope with stress. And all of these things are really good advice at any time. You don't have to wait for a pandemic to do these things. There have been increase in suicide prevention efforts. You came across this article about a high school spearheading suicide prevention efforts. They're working together with a professor at a local university. There's been a big increase in calls to hotlines. Hotlines have been overwhelmed. They've tried to increase personnel and even with taking volunteers to man and woman or person, the hotlines to provide support. Additional support, but that's an area where we really need additional help. We've made very quickly changes in mental health services delivery, and that required changing or suspending policies, for instance, with regard to HIPAA. And so that's the last, there's been a lot of advocacy surrounding mental health services and policy development in how to keep services going for people with mental illness and people at high risk. And so I've alluded to what we need to do for the future. And for the future, again, pandemic or not, we really, many of the things, or probably all of the things I've been talking about have been downstream kinds of things and not upstream. So is the causes of the causes. And so when we think about what's stressing people out right now, a lot of that is related to not having enough money, maybe not having food, and discrimination. And until we address these things, we're going to have health inequities. And the pandemic is highlighting these and exacerbating these inequities. For example, schools being closed and people having online education. And when kids of color and kids with less money and kids who are in rural areas all have poor educational outcomes, and they have less access to the educational online education. And so that is exacerbating the differences, and those lead to health differences, in addition to all the things that kids get at school. Services for disabilities, they get health care, sometimes mental health care, food. So we really need to think through this before the fall, in particular, in my opinion. Health insurance for all would help. It would reduce stress, especially when we have all these people losing their jobs and their health insurance. We need to increase the capacity of the mental health care system. We already came into this with a healthcare system that couldn't keep up with demand. And now it's falling even further behind. And there also are lots of calls to make mental health part of pandemic response planning. Remember, mental health and physical health are intertwined with one another. And finally, make mental health and well-being a priority in all aspects of life. So it's not an afterthought or something to be done after we think, after we think about physical health. It enables physical health and enables us to be fully present and able to enjoy life. And so I would say that if there's ever been a time for public health, it's now. In the interest of time, I'm not going to show you this, but you can watch it later. It's brief, but it's about 2 minutes. And so Dr. Tedros, the Director General of the World Health Organization, gives a brief overview of the policy brief that came out last week on the need for action on mental health amid COVID-19. And what he ends with is that mental health is as important as physical health. Okay, so I'm ready for questions.
Alexis, thank you so much for that really robust conversation going on in the chat. Lots of positive comments about the content and the interesting and thoughtful way that you're pulling together information through a filter that may not be how we're used to thinking about these things. So I'll kick off the first question, and then Josh and I will tag team. And for those of you joining us on Zoom, please do feel free to use the chat function to add your question to the conversation. So Sal has several questions, and I think what I want to do, rather than pose them individually, is to say he's interested in opioid use and what we may know about that in light of COVID, and then also any programs, resources that are targeted to immigrants, ethnic minorities, language appropriate for non-English speakers. So rather than pose a bunch of questions around that, I just wanted to ask, statistically or by way of resources, is there anything that you're able to offer on that?
I am unfortunately not able to offer anything except to recommend one of the upcoming lectures given by my colleague David Patterson on opioid the, I guess, intersection, I can't remember what it's called, but intersection of the opioid epidemic and the COVID-19 pandemic.
Yeah, we're looking forward to that one. I will post the date in the chat. Thanks for that, Alexis.
All right, the second question I have here asks, do you think that public health is starting to turn from prevention into harm reduction practices to therefore destigmatize mental health as well?
That's a good question. I mean, I think there's room for both. It's kind of a, it's a loaded question. So, I mean, it depends on what you're talking about also. Are you talking about substance use disorders in particular?
The person who asked that question, if you want to throw that.
Sorry, it's not you. So I do, in public health, we tend to take a utilitarian approach. So harm reduction, although there is some argument about it, but we would tend towards harm reduction if that would result in less morbidity and mortality than in, say, banning something absolutely.
So we have a couple of questions related to public mental health and trauma. I think some of the questions specifically trauma in minority communities. Rachel, for example, is saying, can you speak to community level trauma and public mental health, acts of violence against people of color, gun violence, etc.?
This is not my area of expertise. And so I'm extrapolating from things that I know about and that the response to the trauma needs to be both at the individual level and the community level. So fact that what we know is that there are protective factors. So, I mean, there are two things, right? There's what causes the trauma, and then there's preventing the negative health outcomes as a result of the trauma. And so in terms of that, and really with all of this, it's not just the individual, it's also the community. And then it's interesting, I don't have an answer here, but where the trauma is also not just an individual level trauma, it's a community level trauma. I don't have any answers, but I do have colleagues who work in these areas. I don't know if any of them have lectures coming up, but it is certainly something to be thinking about and thinking about designing interventions. So
Alexis, interestingly enough, as I am working on my dissertation, I have a whole host of my dissertation is non-public health, it's in educational leadership. So let me just there, I would trust Dr. Duncan's colleagues before you would even go with my stuff. But what I will say is that if you can do a cursory search, I've found a lot of articles on race, discrimination, and outcomes, substance abuse related to race and racism. You can even go as far as looking at high school youth and college youth dealing with race, racism, and other discrimination and its impact on health behaviors, health, etc. So there are quite a few online journals. If for those who are listening, if you have access to a university journal or your public library, if you have access to online articles, there's a lot of research just right down that alley. And I think that that, along with hearing from some of your colleagues as they join us in the future, would be probably a great compliment to each other.
And you bring up, just to emphasize one of the points that I made, I think, or that I wanted to make, which is about going upstream and looking at multiple levels. And all of our health behaviors are, I'd say, informed, facilitated by what's going on in our family, in our communities, in our country. And they make certain behaviors much easier than other behaviors. And and well, I don't even, that's a whole, a whole other topic, but it's very complex. And if we don't embrace the complexity, then we're not going to be able to get the full picture.
That's great. Yeah, it doesn't happen in a vacuum. And I appreciate your connecting the environment and also biological and physiological as well. Janet, do you want to jump on the next one, or I can continue?
Sure. So Susanna is wondering whether we have data in the time of COVID to know whether people's physical activity is increasing or decreasing.
Oh, goodness.
I mean, that's a very snapshot of
referring things to colleagues who know better. So I know that at the beginning it was decreasing. And so I don't know what the latest information is, but I know that the last time I talked about it with one of my colleagues who does study it, that was it was still decreasing. Now this is not necessarily highly correlated, but I also heard the other day that people have gained weight on average. It's a lot easier to gain weight from eat more than it is to exercise. So you could be exercising and eating more at the same time. But it depends on how people exercise too, I imagine. And so if the places where people would like to or usually exercise are closed, also I imagine that things like people who live in places where you have to wear masks to exercise outside, that those might be barriers. We'll see. And we have people at the Brown School who are investigating this question too.
All right, I think this one gets real specific. It says, are there local St. Louis regional or Brown School mental health programs or initiatives that address COVID and opioid-related mental health in immigrant ethnic communities and our social indications of health? So it goes a little on, but about into general differences. And I don't know if we already asked this question, so I apologize, but we're looking for a broad range of connected to COVID, opioids, and related to mental health, immigrants, culture, stigma, language. Just it sounds like a really wraparound question.
Mm-hmm. I am not aware of it. I can think of who would be aware of it at the Brown School. So if that person wants to contact me or Janet, or yeah, we can connect them.
Great.
Right. So John is saying if we're needing an increased mental health capacity, wondering about whether community health workers could be trained with a mental health focus. Curious for your thoughts about that. Curious if you're aware of community health worker programs that have this slant.
So at the moment, let's see. First, my knowledge about this, since I'm an epidemiologist, tends to be more towards the epidemiology. I do know that in resource poor environments globally, that they do employ community health workers, and that they've had success in doing so. I mean, community health workers for mental health services delivery. And the idea is that if you think of it as sort of a continuum, that the people who are most severe are treated by the people, the psychiatrists and psychologists. There aren't enough of them. And then there are community health workers who are trained to deal with less severe cases. And I think that's a wonderful idea. In my experience, licensed mental health care providers tend not to think that's a wonderful idea. And again, that's just my experience. I don't know if we did a study, if that would happen. So, but what we do know is that there's a shortage of providers, and not globally there is, but right here in St. Louis, we have a shortage of providers. And if there's anything that we can do to help ease the burden, I think we should give it a try.
Thank you. So I'm gonna collapse two kind of questions. One kind of has a long, let me just go ahead and go for it here. So one of the questions was, how do you define community? Is it inclusive, diverse, equitable? And then connected to that specifically is, there's a little backdrop of, I think we're all thinking about all the things that are happening right now in Minnesota, in Georgia, even New York, I guess, with the dog and the bird watching.
Oh yeah. Mm-hmm.
And so the question about this has to do with that, not looking at just individual manifestations of health or physical problems, but there's also a community. I think you alluded to this with generational and historical trauma.
Mm-hmm.
So we agreed to psychologists and other mental health practitioners join forces with experts in other disciplines to repair disparities. So I think kind of speaking to that transdisciplinary nature and looking at disciplines.
Wait, is that a question or a comment?
That last part was how do psychologists and other health practitioners join forces with other experts in disciplines to address disparities?
Let's see. Here is a great opportunity to plug our program.
Well, here we go. Yeah,
and
so
our new specialization in public mental health.
yes, we have a new specialization in public mental health. I think and actually that was one of the questions I teed up before I realized that we were gonna have attendees who were gonna plug us with a bunch of questions. So this is really good. So I didn't have to go to this, but our, the luxury of having a social work program housed within a public health program, housed next to a social policy program. By its nature, all of those fields tend to be transdisciplinary in nature, and having them housed under the same roof means that there's a lot of cross-pollination, cross-disciplinary work. And then the other point, of course, is that, within our programs, there are also partnerships outside of our program. So for instance, we have the Center for Public Health, the Institute for Public Health, which does a collaboration with the medical campus and medical faculty. We have faculty members in other areas. We do a lot of stuff with anthropology. We have faculty who teach undergraduates. And so there are a lot of overlap and opportunities for people to connect, because what we like to say is these issues are very complicated, and I don't think any one of these fields should be arrogant enough to think that they have all the answers. I don't think social work, I'm sure you'll find some faculty who are arrogant enough to say like, our thing is it. And I get it, that's just human nature. None of the people on this call are those people. But no, of course not. But when you're looking at these fields, you know that you do have to pull in from these different expertise. And so yeah, it's built into what we do in the fabric of what the Brown School is about.
Really, the key seems to be in, well, first of all, thinking about it, because it doesn't actually occur to everyone that we need to be transdisciplinary to solve these problems. And then in my experience, it's finding the right people to work with. So those people who don't think their field is the be all end all, and who are excited to learn from people in other fields and to create something new together. And that's absolutely what is going to have to happen to really tackle these complex problems at there's so many different components. And the question about community and what is community, and first of all, you can think of yourself, that community is lots of different things. And so we all belong to multiple communities, right? We might belong to community at work, we belong to a community where we live, we might belong to a community at our, if we are go to religious services, communities involved in our hobbies, and so all of those, well, and it's like they all have their own personalities, and so that the group level takes on all these characteristics of their own, and they all affect us as individuals. But it's interesting, it just occurred to me, because we're part of all these different communities, that means that we, just like you were talking about at the Brown School, can cross-pollinate.
It's built in. Can I just add a little testimony to this question? Sarah's other part of her text is, I sleep 7 to 8 hours a night, every night consistently. And since Friday or Saturday, I've slept about 5 hours or less. And I didn't know what it was about. And I had this conversation is right on time with the anxiety and everything that's going on. I really try to distance myself from the media, social media, but you can't help but pay attention to things that are happening in our world. And even though I'm not directly experiencing these things, I am impacted. I think others are impacted when we deal with these issues on such a large scale. And then, on top of it, this is a really tough time where we're dealing with the pandemic at the same time. And there's the brutality that's happening within our communities. And as a father of a 21-year-old Black man, now he's a man, I think that's part of it in the back of my mind of like, what is he coming up through? And so there is this collective experience. And I think that it seems like a very impossible charge to take on, and something that's a lot of us are going to dedicate our lives to working on the rest of our lives. But the point is that, we are uniquely positioned, not only within the Brown School, which is special, but then also with our community relationships with community organizations to really tackle these very complicated issues, because it is personally meaningful and significant to the point where I don't even know the person, but I am affected by it. And so I just thought I'd put that out there, is that the point was well taken. Sure.
Just thank you for sharing that. Thank you for co-hosting. I see that we are approaching time, and I just want to allow Alexis an opportunity for any final thoughts or closing comments as we bring this to a close today.
Well, I want to thank everyone for attending, and I hope that I've increased your interest in public health. And I had one last slide prepared, but is about our specialization, and which I'm really excited about. I'm the chairperson of the specialization, and I've been wanting this for a long time. And it's unique, or fairly unique. It's not. There aren't very many MPH specializations that are related to mental health. There aren't very many programs in the world. And so if you're interested, let's see. This is just a screenshot from our website. So you can take a look there, and you can talk to Josh or me or both of us.
Wonderful. And as we post the recording of this, I can include a hyperlink to this page. I know that people have expressed an interest in possibly having your slides, so I'm going to be hitting you up to see if we can share those on the website as well.
Okay.
And Alexis, thank you so much for today's presentation. Hard questions kicked off, but really, really good discussion. And the really good discussion is going to continue next week. I think based on many of the questions that have been surfaced, many of you will be interested in Matt Kruder's talk. Dr. Matt Kruder on Tuesday is going to be presenting Tracking the Social and Economic Impact of COVID-19. The Health Communication Resource Lab is tracking many of the impacts to people's housing and food and other needs in real time, and he'll be with us to share that data and answer your questions. So encourage people to sign up and join us if they're interested in that program. So with that, we're at time. Thank you all so much for making this a part of your day. We're grateful to have you with us, and we hope you stay healthy and safe, and join us again for another program of Open Classroom. Goodbye, everybody.
Goodbye.